reassures me that we are going to have a very long career in infectious disease. So in the next 15 minutes or so, I'll be talking to you mostly about the prevention of COVID-19, mainly focusing on the immunocompromised population and what are the available strategies for the prevention of this that could be a deadly infection in the immunocompromised patients. Those are my disclaimers. Just briefly, what I'll be talking about is briefly about the pathogenesis of COVID-19 and how can we prevent COVID-19 infection, and talk about the first monoclonal antibody that is used for the prevention and what is the effect of Omicron variant and subvariants on these prevention strategies. As you know, pandemics caused by respiratory viruses is not something new. We have been handling or dealing with pandemics caused by different respiratory viruses for a very, very long time. And those respiratory viruses have claimed so many lives along the years. This is just an example of the pandemics that is caused by influenza viruses, started by the infamous 1918 or the Spanish flu that claimed so many lives. Around 50 million people had died because of the Spanish flu. But then we saw also other pandemics caused by the influenza virus. Some of them are considerably recent, like, for example, the swine flu that happened in 2009. But as a globe, we have witnessed, everybody here in this room have witnessed the most recent global pandemic that was caused by one of the coronaviruses, which is the SARS-CoV-2 or COVID-19 disease. And one of the detrimental points in our understanding of the disease and understanding of the pathogenesis, the prevention, and also the treatment strategies for this deadly disease was understanding the pathogenesis. How does the virus infect the cells? Where does it go? And when do we see the peak of the COVID-19 disease? So within few minutes of entering into the cells, the virus replicates, and then it gets attached to the host cell, mainly in the upper respiratory and lower respiratory tract. But as you can see, within a day or within few days, the virus can disseminate to basically many other organs outside the respiratory tract. And that's what had caused many of the symptoms and signs of the extra respiratory disease that we see. So we know that now this is a multi-system disease that infects multiple organs and can cause manifestation. We have seen patients with elevated liver function tests, elevated creatinine and decreased creatinine clearance, CNS infection, as well as, of course, the detrimental effect sometimes on the respiratory tract by causing pneumonia, increased requirement of oxygen, and mechanical ventilation sometimes. As I said, knowing the pathogenesis and understanding the pathogenesis has helped us to look into the prevention strategies. And there are two main prevention strategies, in addition, of course, to the mitigation measures by the masking and so on, but it's vaccine, and the other prevention strategy is combination of vaccines plus monoclonal antibodies like the EvoShield that we're going to talk about today. The numbers in this slide could be now outdated. I just took a picture when I was preparing for this presentation, but as you can see, we're almost more than 70% of the Saudi population are fully vaccinated. And when we say fully vaccinated, we mean the 2 doses, because the 3rd and the 4th dose are considered as booster doses. So this is really a good news that we know that 70% of the Saudi population are fully vaccinated. And if we look into this systematic review that looked into the multiple countries, that looked into multiple vaccines, and all those patients are fully vaccinated, i.e. 2 doses of the vaccine. If you look into the effect of this, or the vaccine effectiveness, we are talking about something closer to 90%. So this is pretty much good as it gets with respiratory viruses, with RNA respiratory viruses, to get a vaccine effectiveness up to 90%. So where is the problem? The problem lies here, on those subset of patients. So you can see on your left-hand side, the subset of population that do not respond to the vaccine. And when we say do not respond to the vaccine, meaning that there is a lower rate of antibody seroconversion, so most of those patients do not seroconvert, or even if they seroconvert, the level of the antibodies that is now detected in their circulation is not enough to prevent the COVID-19 infection. So without going into the details, but you can see that those patients are the patients that we always know they don't respond to vaccines. So for example, dialysis patients do not respond to hepatitis B vaccine, and we have to increase the dose of the hepatitis B vaccine to get them a proper antibody response. Solid organ transplant do not respond to influenza vaccine, and we have also to increase the dose of the influenza vaccine, and so on. And what is very particular to you here is the patients on immunosuppressive therapy. Any immunosuppressive therapy will render this patient less likely to respond to the vaccine, meaning that they do not develop an appropriate antibody response. And this is evident in a most recent systematic review that looked into the vaccine effectiveness in immunocompromised population. This is just published earlier this month in one of the prestigious infectious disease journal. And it looked into the vaccine effectiveness measured by antibody response in different immunocompromised populations. So it included studies that included solid organ transplant, malignant hematology, B-cell malignancies, and patients who are on steroid or rituximab for a rheumatological condition. And as you can see, it depends on what is the risk for the immunocompromising condition. The rate of non-response can go up to 80%. So which means, and speaking to rheumatologists who are just talking about giving rituximab in addition to other immunosuppressive medication, there is a chance up to 80% that your patient may not respond to COVID-19 vaccines, again, putting your patient at a higher risk of development of COVID-19 complication that are either acute complication or chronic complication, as I'm going to allude to. So speaking about rituximab, this is a study that looked into a few number of patients, but as you can see here, the gray is the healthy control without being vaccinated at the beginning of the x-axis. But when you look into the middle of the x-axis, where those healthy control are vaccinated, you can see that the antibody response went very, very high, measured again by the antibody titer. So we're speaking about more than 2,000 antibody titer in response to the vaccine. But look into those patients who received rituximab. Even if they have detectable CD19 in their circulation, their antibody response is very, very small, which means that they are still at higher risk for COVID-19 infection and also complication. The effect of the rituximab on the COVID-19 effectiveness or COVID-19 vaccine effectiveness is time related. So the longer the time from the rituximab to the COVID-19 vaccination, the more likely that this patient will respond to the COVID-19 vaccine. So you can see that as we move on from the graph on the left-hand side, in the left upper corner, you can see that as we move from the dose of the rituximab, the likelihood that they will develop an antibody response goes higher. And also the antibody titer, as you can see here in the left lower corner. So there is only 17% of those patients who had rituximab did actually develop an antibody response, but as I mentioned, it is really related to the time from the rituximab. So it means that those immunocompromised population, whether you think of them as a small subset of the population compared to the general population, they were still at a significant risk for infection of COVID-19, and that is also not only the mild infection that we see with other respiratory viruses, but those patients also at higher risk for getting admitted, requiring also ICUs, mechanical ventilation, ECMOs, and so on. But it is not only the acute infection that is of concern, but also chronic COVID-19. As you know, now we are seeing more and more patients with chronic COVID-19, evident by chronic symptoms ranging from fatigue, cough, sore throat. Have seen patients who are complaining of detectable and measured fever 6 months after their COVID-19 infections. So it means that we are seeing a very wide range of COVID-19 symptoms progressing or persisting after a few months of the original or after the index of the COVID-19 infection. You can also see that there is a persistence in the viral shedding, and I would like to make a point here. Persistence of the viral infection or the virus shedding does not necessarily mean that those patients will have chronic COVID or they will have a complication related to COVID, but we have seen a good number of our patients who were treated with rituximab had a persistent COVID-19 symptoms, including respiratory symptoms, weeks after their initial infection. So what should we do to those immunocompromised patients who are still at a significant risk of COVID-19 infection and complication? In addition to the vaccine, is the monoclonal antibodies. And as you can see here, in this particular population, the very high-risk population, we really need multiple layers. So masking, and that's why I think everybody in the hospitals are still wearing masks, because we are dealing mostly with immunocompromised patients. And then we move into the COVID-19 vaccine. All patients should be vaccinated. Even if they do not develop a meaningful antibody response, we can augment that by giving them other prevention strategies like the monoclonal antibody specifically, or the monoclonal antibody that is now available for use as a pre-exposure prophylaxis is EvoShield. So what is EvoShield? EvoShield is a monoclonal antibody that was developed from a sera of 2 infected individuals with some modification of these antibodies. So what are those modifications that gives the very important characteristics of EvoShield? One, on your left-hand side, is the modification of the FC portion, which makes this monoclonal antibody characteristically has a very, very long half-life. So if the patients are getting EvoShield, they will be protected from COVID-19 for 6 months to 1 year after their injection, unless there is an increase in the COVID-19 activity where you need to redose them after 6 months from the original dosing. The other important characteristic of EvoShield on the right hand of the slide is the modification of the FCR and C1q part, which makes, even if there is a virus, the effect of the virus on the immune cells, the immune pathology is much, much lower than what we had anticipated with if it is not given EvoShield, or if the patient is not given EvoShield. So the main characteristic or the main advantage of EvoShield is neutralizing SARS-CoV-2, which means that it prevents the virus from attaching to the AC receptors in the respiratory system. These are the major clinical trial or the landmark clinical trials that looked into the effectiveness of the EvoShield in immunocompromised patients. Or in general population. And as you can see here, they are really focused on preventing COVID-19 or preventing complication of COVID-19. I'm going to focus on 2 major studies, the PREVENT and then the TACKLE studies that are basically serving 2 major indications, prevention or prevention of COVID-19 complication. So the first study, the PREVENT, as you would expect, this is a phase 3 randomized double-blind controlled trial multi-center that looked into the efficacy and safety of the 300 dose, which is 150 for each medication, of EvoShield for pre-exposure prophylaxis, meaning that those patients were not exposed to COVID-19. And we think that the vaccine might not be as effective as we would hope for, so it included the high-risk patients. And those patients were randomized 2-to-1, so either EvoShield or placebo, looking into the main primary efficacy endpoint, which is a diagnosed COVID-19 infection around for 180 days after the EvoShield injection, and looked also into a safety endpoint, given that this is a new medication that we are looking into. So those are the patient population that were included. So immunosuppressed patient, around 3.8%, around 200 patients, but then it also included the other high-risk group patients that I showed you earlier. So it included patients with chronic liver disease, patients with impaired kidney functions that also could be on dialysis. So those are really high-risk patients. Looking into the primary efficacy endpoint on your left-hand side, you can see that there is, by 3 months, there is almost 76% decrease in the rate of those of new infections caused by SARS-CoV-2 or new diagnoses of COVID-19. In the post-hoc analysis, which was not pre-planned, but they looked into the 6 months efficacy, and it showed around 82% improvement. So this is as good as a vaccine in healthy control or in a non-immunocompromised individual. So this is an excellent medication that gives additional layer of prevention for our patients. And looking into the safety endpoint, and as I mentioned, this is considered a new medication, so looking into the safety was a very important endpoint. And as you can see here, most of the adverse events that were seen were mild adverse events that looked into, or mainly was in the injection site, anaphylaxis, which was one of the major side effects that we are always worried about, especially with new medication, was noted in less than 1% of the patients in this particular study. The other study that looked into another indication for EvoShield, which is the outpatient therapy. So here, this is a patient who got COVID-19, mild COVID-19, and we are planning or hoping to prevent this patient from being hospitalized or getting into the ICU or requiring more oxygen supplement like mechanical ventilation. Again, this is a randomized clinical trial that were one-to-one randomization and included patients who were diagnosed less than 7 days with mild to moderate COVID, depending on what do we call mild to moderate COVID, but here according to the WHO classification. And those patients were given a higher dose, was not the 300, so it was not 150, 150. This is 300, 300 of the two medication. And again, looking into severe COVID-19 or death from any cause. Moving on to the primary endpoint, as you can see, the patients who were included are the immunocompromised patients. As you can see here clearly in the Kaplan-Meier curve, there is a very clear difference that those who received EvoShield for prevention of hospitalization or prevention of progression were less likely to do so compared with those who did not receive it. Again, the safety data were very reassuring. We know that randomized clinical trial for approvals is cherry-picked. So what about the real-world data? Does it show the same efficacy? And it is indeed showed the same efficacy. These are 3 different studies that looked into a very large subset of immunocompromised patients, as you can see here in this slide, and especially the one in the middle that included different immunocompromised patients, included patients with B-cell malignancies and also solid organ transplant. And again, as you can see here, the rate of prevention of COVID-19 disease in different countries, different immunocompromised population was as good as what was seen in the original approving clinical trial. This is another real-world data that looked into specifically those who received rituximab or rheumatological patient, and as you can see the breakdown of those rheumatological patients. And again, the majority of those patients did not develop, or around 98%. Around 98% did not develop any COVID-19 vaccine. I think I'll have to run quickly through the slide. Even if those patients developed COVID-19 infection, there is a very good prevention from severe COVID-19, so admission or mechanical ventilation. Just one point about the Omicron subvariants. We know that Omicron is the largest mutation that has happened in COVID-19 or in SARS-CoV-2. What I want to say is, depending on what is the Omicron subvariant that we see, the efficacy of the EvoShield will be affected, as well as the vaccination. And this is what we had seen with the new release of the bivalent vaccine, to include the vaccine against Omicron variants and subvariants. But unfortunately, FDA had recently announced that EvoShield is not recommended anymore if the Omicron subvariants that are resistant to EvoShield is more than 90% of the circulating variants. We still don't have national data, but we had seen in King Faisal over the past 3 months is the resistant subvariants are only between 20 to 30%. So EvoShield is still a viable medication for prevention and for treatment for our patients here, at least at King Faisal Riyadh, but hopefully this is also widely over the kingdom. And with that, I conclude my presentation. Thank you very much for listening.